We want to move on to our panel, which is going to look at what I think we'd all agree is one of the really critical aspects, roles that hospitals play, which is emergency care. In some ways, the highest and best use of the talent of these institutions. We're going to hear from some folks who've had to deal with some unexpected tragedies and natural disasters. 9/11, anthrax attacks, SARS, bird flu, Hurricane Katrina, Aurora, Newtown. Those are headlines that come out of my business, but it's often the folks in the emergency rooms of hospitals are the ones who have to deal with the consequences. Most recently, we had the April's Boston Massacre bombings, and then Superstorm Sandy, which hit the East Coast a year ago. Those illustrate the crucial need to be prepared. The group that we're bringing on has some powerful stories and strategies to share. So I want to bring them up one at a time. With us from New York City is Tony Shorris. He's the Senior Vice President, Vice Dean, and Chief of Staff at NYU Langone Medical Center. During Sandy's power outages and floodwaters, the hospital was forced to evacuate hundreds of patients. I'm sure you remember the harrowing photos and the videos of that situation. He's here to tell us how they fared and what the hospital learned from us. Ladies and gentlemen, Tony Shorris. Also from New York is Geoffrey Bhaskar, Vice President for Safety, Security, and Emergency Services at New York-Presbyterian Hospital. When Sandy forced the shutdown and evacuation of city hospitals, New York-Presbyterian scrambled to handle the influx of patients while making sure its own facilities and people remained safe. I may need some emergency help around here. What's going on? Please welcome Geoffrey Bhaskar. Thank you. Next, we have Dr. Eric Gorelnik, Medical Director of Emergency Preparedness at Brigham and Women's Hospital in Boston. He was on the scene during the marathon and watched the response unfold. Brigham and Women's took in 39 injured people, including 23 within the first hour. How the hospital successfully treated the victims is already being used as a model for emergency preparedness. Dr. Eric Gorelnik. And finally, guiding the discussion is my colleague, U.S. News Executive Editor Margie Mannix. Margie is no stranger to healthcare coverage. She's a former editor of Health and Medicine Division for U.S. News. She currently oversees our digital magazine, U.S. News Weekly, and our consumer guides. And she has shepherded the wonderful programming that we've had in this conference for the last 3 days. So, round of applause, Margie. It's all yours.
Thank you. As Brian mentioned, East Coast hospitals have found their emergency response plans tested to the limit in the face of several major events. Can each of you walk us through these incidents and how the different elements of your emergency plans unfolded? After that, we'll discuss the most important lessons learned, but I think it's important for our audience to just give a brief overview. So, Tony, let's start with you.
So just about a year ago, on October 24th...
Pass it down. That's our emergency response.
Yeah. We're ready. That was our first lesson. On October 24th, a little more than a year ago, Sandy became a level 3 hurricane in the Caribbean and began working its way up the East Coast. It arrived in New York on Monday, October 29th. At that point, it had lowered its level as a hurricane. It was actually a tropical storm, but of an unusual severity, as I'm sure you all remember, an enormous scale storm. The largest hurricane ever on the East Coast, the second largest event in American history after Katrina, causing $68 billion of damage and hundreds of lives, 48 people lost in New York City alone. Importantly, the storm had an unusual combination of attributes to it, the scale of it, the way the winds blew, the time of day, the time of the season, which led to an enormous tidal surge in the New York harbor. A tidal surge that well exceeded what anyone had ever forecast. It well exceeded what we had experienced in 1821, the last time we had anything even close to Sandy, and therefore well exceeded any of the plans that the city or any of us had in place. It began hitting Monday in the afternoon, throughout the evening. NYU itself is located, for those of you who don't know Manhattan, it's on the east side of Manhattan, really only as wide as this room is away from the East River, separated by the FDR Drive. The water began rising with the tides, the winds, again, the combination of Sandy's effects led the water to begin pouring over the side from the river into the hospital's basement. The hospital is actually built on landfill and has a substantial component of its infrastructure below grade. It's everything that's normally below grade, lots of heavy equipment, MR machines, gamma knives, and so on. Much of our emergency room, our kitchen, a lot of the infrastructure associated with the hospital. And because it's an academic medical center, a lot of our research facilities, animal facilities, and the like, also located below ground, along with classrooms and other things associated with the academic side. Within about an hour, 15 million gallons of contaminated water came into the basement of the hospital. The water was of such force, it bent metal doors and toppled bricks and other things that had been put in place and crashed from one building to the next. The basement's all interconnected. In the course of that, it began to knock out infrastructure for the hospital, eventually leaving the hospital without power or light, as the Con Ed system that supported the utility for the region, our regional plant was 20 blocks south. It was also overcome with water and exploded and put the entire part of Lower Manhattan into darkness. So the hospital was left by late Monday night without power, without access to its core infrastructure systems, and with some 300 plus patients in the hospital facility. Marty, did you want me to talk a little bit about the prep right before? Yes. So we knew it was coming, and so like any of us here, we began the preparations for an event that was headed our way. We had had a hurricane the year before, Hurricane Irene, which the hospital sustained very little damage with, but we did evacuate the entire hospital for Irene. This time we felt, based on that experience and our guidance as to what the level of water would be, that we could sustain a substantial shelter-in-place strategy. So we began bringing the hospital down slowly. We, starting 5 days before, began canceling elective surgeries, we shut down the emergency room a couple of days before, and we began moving lower acuity cases out of the hospital. The issue, and it was left obviously to our clinicians to make the decision, it's a tertiary quaternary care hospital and had a lot of people who were at grave risk of even the impact of being moved. So given the infrastructure of the hospital and having sustained Irene pretty well, given the forecast of the storm, which until that afternoon was estimated to be about 9 feet of surge water, we felt we could leave about 300 some patients in the hospital. As I mentioned, the waters were much higher. They rose to 14 and a half plus feet where our campus is. They overwhelmed the infrastructure, excuse me. And we ended up having to evacuate the whole hospital that evening. We had some, again, 300 patients, mostly very high levels of acuity. We were actually blessed by having the chairman of our board in the hospital that night and the namesake of NYU Langone Medical Center. So we had a very difficult evening, as I'm sure many of you saw, everything from preemies to cancer patients to people there for very complex surgical cases. And we, thanks to an unbelievably heroic effort by the nursing staff, the physician staff, and because it's a medical school, a lot of the medical students, and certainly our house staff, did an amazing job of bringing all 300 people out during the course of that evening into the next morning and bringing them to other hospitals. And that's probably where we could turn it over.
Okay. Jeff, you took in some of those patients, right?
Yes.
Tell us what that was like and how you prepared for that.
So at New York-Presbyterian Hospital, our response was more about patient surge and how we were going to deal and handle with taking in many of these evacuees. Hurricane Sandy tested all aspects of our emergency response plan at New York-Presbyterian Hospital. Situations and scenarios that we had only discussed at tabletop exercises became a reality. Our planning, very much like Tony's, began around 96 hours out. And we started by assessing the various different weather models and hoping that none of them would be true. But it turns out that the European model was exactly right on, and this was going to be a serious catastrophic storm. We began by assessing our staffing plans, knowing that transportation was potentially going to be shut down in and out of Manhattan, and that 70% of our employees rely on public transportation to get to work. So this was something that we knew we had to plan for. We knew we had to identify housing locations for our employees, how we were going to feed these employees during the storm. And as we made final preparations for our preparedness, setting up our command center, setting up our communication strategies for how we would communicate to our employees, to our patients, we received an unexpected phone call from the Commissioner of Health, Commissioner Nirav Shah in New York State. And Commissioner Shah had informed us that power was going to be shut off to Lower Manhattan as a result of the impending surge. And we evacuated our Lower Manhattan hospital, 130 patients, prior to the storm making landfall at our other New York-Presbyterian hospital facilities. As we hunkered down in the command center that night, that Monday night when Hurricane Sandy made landfall, our lights flickered. We at the Weill Cornell Medical Center are also located on the East River, several blocks up from Tony, a little bit further in than NYU Langone Medical Center is to the river. We went from normal power to generator power, and we wondered what would come next. Then we saw the news reports coming over. Hospitals evacuating, NYU Langone Medical Center evacuating. And we said to ourselves, how would we continue to be here for our patients and for this city? And we knew then that this was going to be an event where we had to surge. We had to help as many of our institutions in New York City as we possibly could. And we took in over 600 patients at our New York Presbyterian healthcare system facilities throughout the storm. And this went on not only for days or weeks, but months. On top of Hurricane Sandy, in 2012 in the East Coast, we were hit with one of the hardest flu seasons. So we had to come up with additional surge capacity, unlike anything that we had ever planned or thought about in our planning. Creating tents. Now, where do you set up a tent in New York City? So certainly a real challenge for us and really changed our thought process around preparedness for the future.
Okay, thank you. Now let's turn to the Boston Marathon bombing. You were there. Set it up for us, what you saw and what plans were in place.
So the morning of April 15th, 2013, we rounded in our emergency department in our hospital to prepare our staff for what we typically would expect from marathon injuries, dehydration, blisters, etc. I, with some colleagues, went down to a clinic that we staff near the finish line at the marathon bombings near Copley Place. And at 2:49 that day, we had approximately 66 patients in our 55-bed emergency department, a typical Monday afternoon. 1 minute later, there were 2 explosions within seconds of each other near the finish line of the Boston Marathon. 2 improvised explosive devices went off. Immediately, there were pre-positioned fire personnel, law enforcement, EMS, several thousand volunteers, including physicians and nurses, bystanders, veterans, who swarmed on top of the survivors. They moved barriers. They got in there. They applied tourniquets, thinking back to training that several of them had gone through several years in the past. Those patients were rapidly triaged in a medical tent that was pre-positioned according to our plans and dispersed over several hospitals throughout the community. In fact, where the marathon finish line is, within 2.5 square miles, there's 5 level 1 trauma centers in Boston and Boston Children's Hospital. So we were fortunate based on that location. These patients were rapidly dispersed, remarkably evenly, led by Boston Emergency Medical Services, and we responded. I was part of one of the teams that went down to the finish line and provided care and then went back to the hospital. While this was going on in the field, back at our institution at Brigham Women's Hospital, our leaders there, our emergency medicine physician, attending physician, our nurse in charge, and our emergency manager huddled at the front desk in the emergency department. They went down the checklist that we had designed as part of our emergency operations plan, and they needed to do 3 things. Number 1 is they needed to communicate across the organization to operate and enforce our disaster plan, which is our Code Amber, to make everyone aware that we need to build capacity, not only in the emergency department, but across the hospital At that time, at 2:50 that day, in our 42 operating rooms, we had 30 active surgeries, so we immediately needed to do number 2, and that was build capacity. Build capacity in the ED, build capacity in the operating rooms. And that's what they did. They rounded in the emergency department, throughout the hospital, in the operating rooms, built capacity. They were able to stand up 8 operating rooms within 18 minutes. And in the emergency department, we had internal medicine resident physicians, psychiatrists, others who took charge of patients that could be admitted, brought them upstairs to open beds, built capacity upstairs so we could accommodate all those patients that came in. Within the first half an hour, we got 19 patients, and overall, we got 39 patients. Those patients were met at the door by an attending physician. They were triaged to different pods and beds within the emergency department, and then secondary triage was performed by another team led by a trauma surgeon. They made decisions on who needed to go to the operating room in a rapid fashion and who could wait, and 9 patients went emergently to surgery. The first patient went to surgery 26 minutes after they arrived at Brigham Women's Hospital. So again, overall, 39 patients we took care of that day, 23 in the first hour. And we were just part of the story in Boston.
Okay, thank you. Tony, I'm going to start with you. What was the biggest lesson that you learned from Hurricane Sandy? And if you could also talk about how, what you learned in the aftermath and how long it took you to get back online.
So I've been through actually a couple of different disasters in totally other settings in prior lives. And to me, there are 3 things actually that I just want to mention that I thought were true in my other disasters, which were the 93 Trade Center bombing and 9/11 and then here. First is, and again, I want to separate a little bit the challenge Eric's talking about and the challenge Jeff and I are talking about is different in one really important way. There are disasters and crises that you have notice of and those that you don't have any notice of. So the bombing, obviously, is the kind you don't have any notice of, as was 9/11 or the 93 trade bombing. Storms like this, we had prep. So some of these issues are going to be, and notions are going to be relevant to those where you have warning. So 1, think about what happens if 2 bad things happen, not 1. Too often our planning is all about 1 really bad thing happening. In our case, we would have been okay if there had been a blackout. We might have been okay if there had been a flood. But when there's a blackout and a flood, it adds a different set of complexity. And I could go through that with several other incidents I've been through. 2, and we learned this deeply during Sandy, you need to expand your planning well beyond the forecast risk envelope. So we had planned thoroughly for what Sandy was going to be, the 9-foot level storm, 8-foot, 9-foot, 10-foot. We hadn't planned adequately for a 14-foot storm, as nobody had in New York. The third is that because crises are by nature activities that exceed the capacity of an organization to handle, because if actually the organization could handle them, there really wouldn't be a crisis. That means that the sinews of an organization, which is its communication ability, are the most important things, because you can't possibly plan for all the things that are going to happen. And so communication, redundancy, depth, breadth of communication, both within the institution and outside the institution, and the preparation of that, both in the 96 hours before that Jeff and I were talking about, but also long before that, those to me are critical elements. And the final lesson, and it's true for all of you who've been through these disasters, I'm sure, is you're only as good as the weakest link. So the power at NYU went down, not because there wasn't sufficient fuel on site, there was plenty. It wasn't because there weren't emergency generators, there were lots. It wasn't because the emergency generators weren't on the roof. They had been relocated years ago. It turned out that it may have well have been because a couple of pieces of electrical equipment that were still in the basement powered some of the pumps that brought the power to the relocated emergency generators. So it may turn out that all of this preparation, which was actually excellent, failed because of a very small piece. And that's routinely true in all systems. So those are the 3 things, Marty, I'd honestly say. Now, in terms of recovery, the hospital is actually back and operating within 60 days, which was an incredible effort, and it was made possible in great part by a lot of assistance from FEMA, which was on site and fronted us a fair amount of money almost instantly, which was an amazing triumph for what we often hear about FEMA, and was incredibly supportive throughout. It was made possible because we had a lot of resources, and NYU is a wealthier hospital than some hospitals, and we could access that. And because we were in the middle of an enormous building program, we're in the middle of a $3 billion campus transformation on that block, we actually had a lot of infrastructure and construction teams in place. So that helped us get the place back up more quickly, I think, than many people might have thought.
Okay. Jeff, did you want to add something, Eric?
Yeah, it's an interesting point, Tony. You talk about sort of a planned versus unplanned disaster. And we think there's, obviously, all of us would think there's tremendous value in that planned disaster aspect. We certainly like to think we were ready for an event like the bombings. I don't know that anyone can really be fully ready for an event like that. But in Boston, for example, we think about 3 days as planned disasters. We think about July 4th, when about 500,000 people come down to Boston. They watch the Boston Pops and the fireworks on the Esplanade. We think about April 15th, or Patriots' Day, when it falls every year, and several 100,000 people come down and watch the marathon. And we think about New Year's Eve. So with that in mind, before the event, we have multiple meetings, we do exercises, and we form that incident command structure. So there's certainly value in thinking about that, but it's, again, the challenge is to have that redundancy in your organization to be ready every day for Saturday at 2 a.m., something that's going to happen.
Well, emergency preparedness is about continuously asking yourselves the question, are you really prepared? And incorporating lessons learned into your programs going forward. Certainly during Hurricane Sandy, as we look at previous events, usually a disaster is a day or a week. And it's in the DNA of healthcare workers to be able to respond, to rise to that occasion and take care of patients, to save as many lives as possible on that day or during that week. But Hurricane Sandy lasted months, and New York-Presbyterian Hospital was one of the only facilities in New York City that was operational through February. So our preparedness program now is really about how do we prepare our employees for that marathon versus a sprint? How do we keep our employees motivated, that heightened focus, to remain in that response phase for many months? That was something that we had not contemplated or had built into our preparedness program. The second lesson learned amongst many was around patient satisfaction. We expected that even though our patients were being treated in hallways and in atriums, being one of the only places in New York City where we could get care, that our patients would be appreciative to be receiving care. But perhaps this is a unique phenomenon to New Yorkers. We don't know. But we had to put teams out there that would round on these patients, explaining what was going on, apologizing for the delays. We had a real impact on our patient satisfaction scores. And certainly we still feel that to this day, the impact of having an additional 600 patients in your system has on patient satisfaction. So many other lessons learned, but those were two areas that we had not previously planned for or thought about in our disaster planning.
And Eric, you were telling me the other day about some of the things that you learned, and some of them seem very simple, but so very important, like the identifying the patients.
Yeah, one of our significant challenges was, imagine influx, in our case in the emergency department, of 19 patients within half an hour, 39 in a short amount of time. And each patient, as they come in, are not identified. Some of them are talking and some are not. We deal with this on a routine basis with 1 or 2 patients that come in due to a motor vehicle collision or a gunshot wound. But to have that huge influx come in at one time overloads our traditional information systems, the way that we register patients, the way that we get them in a room to evaluate them, et cetera. So in this case, we had 39 patients come in a short amount of time, and on our virtual tracking board, every patient had this naming convention that said unidentified and a series of digits. And imagine if you're a clinician, if you're another provider, and you see this sea of names that all look very similar, and you've got to track them through the system, follow up on their x-rays, their blood work, et cetera. That could really lead to a lot of near misses. So we had a clear target. That target was July 4th, one of those other planned disasters, to rectify that. And we looked at what was out there for best practices and redid our naming convention so it's much simpler and clearer for providers. And this was a challenge not just for our institution. We obviously have done a bunch of debriefs within the city of Boston. And this was really a challenge across all the level 1 trauma centers and the children's hospitals. When you get this influx of patients, what's the most efficient way to deal with that? And so we've tried to leverage each other's experience and build on that.
Jeff, your hospital has built in some preparation. For example, your isolation capabilities and for a bioterrorism attack. How do you decide as an institution which threats among the many that this nation and this world has experienced, how do you decide which ones to prepare for like that?
Sure. So our emergency management program is based upon risk. There's no such thing as absolute preparedness. You can never be prepared for every event. But what we do each year is look at the various different risks that are out there. We look at lessons learned. We look at experiences from other institutions around the world. And we identify vulnerabilities in our infrastructure and look to harden our infrastructure and make investments as much as we possibly could. It's always going to be a balance. You can never have that full preparedness. And really what we do, it's about a mindset. Our preparedness is very much focused on taking that all hazards approach. So we evaluate risk, we prepare for incidents, but then we take that approach no matter what the incident is going to be, that we are ready to respond. And we try and make investments where possible. We try and make improvements where possible. And as I mentioned earlier, we're continually challenging our team to say, are we really prepared? Looking at what occurred during Hurricane Sandy, going back and saying, if this wasn't a once in a 500-year storm, what else could we do?
Okay. What is the next big threat? I mean, or is it all of the above things we've experienced? Is it one that you think is looming over us more? For each of you, what are the next big threats or one threat that you're working to prepare for? You want to start?
Well, I think active shooters are a big one when we think about risk and we think of our hazard vulnerability analysis or assessment. Certainly, active shooters are on the uptick. And what I mean by active shooter is an individual that comes into an organization, and in our case, we're talking about a healthcare facility, and brandishes a weapon and starts shooting at individuals. We just had this recent incident here at the Navy Yard, for example, in DC. So we have really moved that up with regard to our assessments and made that a priority right now in our response.
I would agree with Eric. Much of our emergency preparedness over the years has been focused on hospitals being the beacon in the night, hospitals being there for the communities and being able to respond. It has not focused on hospitals being the ones who become compromised. And as we go forward, we really need to think much more about how, as healthcare institutions, we could harden our infrastructure. We could be prepared, develop mitigation strategies so that we could continue to be there for the community. So situations like an active shooter, everyone's worst nightmare, looking at abductions, events that impact the organization, that's certainly something that we need to incorporate in the future. And as we look at a category of risk, or a category of what's to come next, I think we're hearing more and more of those events, these natural man-made disasters, as well as individuals looking to cause harm on a facility.
Okay. Tony?
I think the way I try and think about this a little more is I disaggregate risk into two components, likelihood and consequence. And clearly there are elements that are causes for concern that fall more into one of those than the other. So in terms of likelihood, I certainly wouldn't disagree with these guys. It's one we think about a lot, and it's also fairly top of mind at the moment for lots of reasons. In terms of consequence, that obviously has potentially large consequence, but the kind of regional disaster that we were talking about with Sandy or Katrina or others, those remain on my mind, and I want to make sure it doesn't dominate our thinking, because there is a tendency to take your most recent disaster and make that the main thing you're thinking about. Just that's a natural human response to any kind of decision-making problem. But I think it's pretty clear that the environmental trajectory of the world is such that those kinds of versions of those disasters, we'll never have Sandy again. It will never be exactly Sandy at that time of day, at that time of year, at that type of storm. But tidal surges are going to become increasingly common. For locations like ours or others that are on waterfront facilities, this is going to become an increasingly common likelihood. So in that case, the consequence is potentially enormous because it's about the hospital as victim and the hospital as beacon, both. The consequence is very large, and I believe the likelihood is only increasing. So I'm constantly talking to our guys to make sure that they don't hear the phrase 100-year storm and wipe their brow and say, good, I'm good for 99 years now. That ain't how it works. So I remain fairly focused on environmental risk associated with climate change.
Back in 2006, U.S. News had an emergency preparedness summit, and I do remember that quite clearly, and we had a doctor that was lived out of his car for 3 weeks during Hurricane Katrina, and the dominant topic of that day was communication. Nobody could communicate with their own doctors, the nurses, and much less the outside world, law enforcement, the community. Has that improved communication in your hospital and outside? Has that improved over the years?
Yeah, we've come a long way in communications, and certainly as we go back to September 11th and we look at what occurred in New York City, we have really evolved. But no matter how far we've come with communications, that is always the #1 lesson learned after every event, every incident. When we do a situational debrief of that disaster, communications always comes up. You can never communicate enough to your employees. You can never communicate enough to your patients. And just when we think that cell phones are stable or internet technology is stable, it fails. Every disaster, telecommunications will go out, and you're constantly looking at what other ways to communicate. So we've made lots of investments and we've had lots of focus on our communication strategies, looking at how we could be more in sync with our social media strategy, looking at ways that we could better reach out to our employees, mass notification systems that we have in place. But there's not one communication strategy for every employee, and there's not one communication strategy for every patient. So it's really got to be all-encompassing, and we constantly have to be looking at better ways to communicate.
I also want to just broaden as much as possible the notion of communication. So these are all big organizations, right? There's 21,000 people work at NYU, there's many more at New York-Presbyterian. These are huge organizations, so there are complicated communication issues inside the organization. But the real issue, and it in a way harkens back to that chart that Tom put out, right? The concentric circles. So we have enough trouble trying to figure out communication within the middle of the circle, the hospital itself and the hospital's immediate community. But the truth is, in these large-scale disasters, we're only one cog in a much larger care delivery system. And the issue of communication was very problematic in New York City, not so much within the institutions, we had our challenges, but between institutions was complex, and far worse when it was amongst institutions that are not alike. So New York-Presbyterian and NYU talk 99% the same language. By the time we get out to ambulatory care providers, it can get a little different. By the time we get to individual physician offices or places where people are having transfusions, can be different. By the time we get to nursing homes, where there were thousands of vulnerable residents who were essentially in a healthcare context, it's very different. And the level of communication integration among different kinds of institutions gets geometrically more complex. So I think about communication not only within, but across these institutions, and that's where I don't think we're as strong as we should be.
That almost leads us to a funding question, obviously. Is there enough state and federal funding to improve communication as well as everything else you need for disaster and preparedness? And does the private sector fit in here anywhere?
Yeah, I think just really quickly touching on that point about communication, and we'll go back to that. I can't agree with you more. Working on communication across organizations, especially across disciplines, was a significant challenge. It was almost easier to communicate during the acute event in the marathon and the response. But it wasn't just that one day. It was over the course of the week that we had to respond. We had a bomb threat at our institution the following Wednesday. On Friday, we locked down the city during the pursuit. And that caused a lot of issues associated with communicating with our clinics. Again, we have 16,000 employees going across all our various campuses, so that was a big challenge. And Twitter is a game changer. There's no question, right? There was a bomb threat at Tufts Medical Center during the event. They had to evacuate their emergency department. There was a lot of tweeting going on. Many emergency departments and operating rooms found out about the bombing via Twitter and activated their emergency response plans via that. So the question is, how do you vet that information up front? What's real, what's not, what do you react to, et cetera? So going back to your other point, you know, we've had a downtick in funding, federal funding. This year we were cut by 33% from the Assistant Secretary in Preparedness response. So we're really trying to work with the private sector to see where we can look at opportunities for funding, opportunities for engagement and relationships. We relied so much on the private sector that day during the course of the week, and using some of their facilities. Hotels were very willing to give up some space across the city so that our city leaders could respond in appropriate fashion. So I think there's a real opportunity to build those bridges across the public-private sector and integrate them in these big drills that we do, not just on the healthcare level or on the public response level, but in the public-private sector.
That's not happening now?
It is on a smaller amount, but I think we need to build it up quite a bit. Yeah.
All right. Jeff?
Yeah, we've experienced a decrease in funding certainly over the 12 years that the Department of Health and Human Service grants have been in place. And as hospitals are looking at ways to cut costs, certainly the focus is going to be much more on quality of care, the clinical aspects. No one's going to come to your hospital because you have a brand new generator or you have your fuel tanks that are hardened. So it's going to become really challenging to prioritize funding for emergency preparedness initiatives. But certainly the cost of not making those investments and having infrastructure destroyed and impacted and the loss of patient revenue far exceed those investments. So we're going to have to find ways to prioritize. I think we could do a much better job at the state and federal level. Tony talked about earlier how we could work together collaboratively. If we could look at building medical districts, making some of this grant money and grant funding available to these coalitions of hospitals that work together rather than individual institutions, I think we are going to be much more prepared. No one's going to remember if one institution did well versus another institution. They're going to look at how the community did, how hospitals work together to take care of patients. And I think that's really where we need to have more focus on federal funding.
Okay. And again, the metaphor of you're only as good as your weakest link applies to the healthcare system as a whole. And so even if we have some relatively, and we are among the relatively more successful financial institutions around, much as we struggle, there are lots of safety net provider hospitals that are miles away from being able to make these kinds of investments. And when you go down the food chain to nursing homes and community-based providers, they're not even close to being able to do that. And if they're key elements in the delivery system for emergency response, the weakest link is way too weak.
Eric, turning to another topic, one of your colleagues wrote in the Journal of the American Medical Association that the emotional effects on caregivers and bystanders cannot be underestimated, and preparations for this should be initiated. Has Brigham and Women's begun this effort, and what exactly is this effort?
Yeah, to sort of use a metaphor that you used earlier, Jeff, you know, that day the marathon ended, but we began our marathon. And that night, myself and my chair both called Rich Zane, who was our former vice chairman at Brigham Women's. Several months prior, he'd become the chairman at University of Colorado, and he'd been there for 2 months, and then the Aurora shooting happened. So we called him that night and said, Rich, what's the next step? What's the most important thing to focus on? And he said, debrief. Debrief 3 times as much as you think is necessary. So we focused that night and began working across the organization, as other hospitals did across Boston, to work with our staff to get them the support that they needed, with psychiatrists, employee assistance programs, social workers, chaplaincies, et cetera, as a team effort to focus on our employees, our healthcare providers, and not just physicians and nurses, but housekeepers, maintenance, everyone that saw something, other patients that were exposed to this event. And that continues to this day. We continue wellness efforts, and we're moving forward.
And what about the bystanders?
Yeah, so the bystanders, again, is significant. So Boston Public Health has really reached out and tried to do some surveys and engage the community on this. We're working on a study across specifically healthcare workers to see look at the toll of acute stress reaction, PTSD, what services were out there, and we're hoping to get that information out there to the public. There's been some work on that from Katrina, from other events, but not so focused on healthcare workers and their response.
Okay. Yeah. Did you want to?
Sure. As I walked through the hallways after the storm, I ran into an employee, one of my paramedic supervisors. His name was Tony, and I said to Tony, "How is everything at home?" And Tony said, "I've lost everything in my home, but my family is safe, and I knew I needed to be here to take care of our patients." And it was stories like this that we heard across all of our institutions. We had employees who parked their cars on the opposite sides of the bridge because they didn't have gas to get into work so that they could be here for patients. And it begins with having personal preparedness plans. The cornerstone of our emergency preparedness program is that all of our employees during orientation receive an emergency preparedness plan. And we expect our employees to activate those plans so that they know their loved ones are safe, their spouses are safe, and more importantly, their spouses, their pets are safe, and that they have plans and could be committed to taking care of patients. So that is really what starts the foundation. And then when your employees are at work and we need to make sure that our management team is visible, continuously walking around, doing whatever it takes to provide the resources, setting up centers and providing funding and housing for any of our employees who were affected or potentially could have an event. So that's really what it's about. It's about those personal preparedness plans, and then when your employees are there, making sure that as a management team, you're going above and beyond to demonstrate to your employees how much it means to you to have them there to take care of the patients.
One of the things that was very moving about it, and it is true, I'm sure, at all these institutions, is how the employees supported each other. In post-Sandy, our employees got together and put together a fund that they all contributed to support those whose families were in homes were most destroyed or their families most injured. And over 10,000 of our employees ended up contributing, some probably $20 or $25, others much more, so that they could show some sense of that bonding and commitment. It was very, very powerful.
Okay. Well, we only have a few minutes more, so I thought I'd end it with a hypothetical question to all of you. And Jeff, you touched on yours a little bit, but I'm going to go back to you. And I don't expect a long answer, just something brief. But say an employee of yours comes to you during a disaster like Superstorm Sandy. They're worried about their family. They're super worried, but you really need them there. What do you say to that person when they're in that state of mind?
I make sure that we have set up whatever that employee needs so that they could be there for our patients. And as I mentioned, it starts with that personal preparedness plan, but we need to make sure that throughout the duration of the event, and even to this day, we continue to provide our employees housing, food. We have many employees who still do not have their homes back. So I try and provide whatever comfort that I can. Our management team provides whatever comfort and resources that we can to our employees who made tremendous sacrifices to be there to take care of our patients.
Okay. And Eric, being an emergency department doctor, you're asked to assess the readiness of an emergency department in a small hospital in upstate New York. You walk into the emergency department. What is your first question? What is the first thing you look for?
So before I would walk in the doors, I'd put on a little yellow vest that says facilitator, and I'd walk up to the front desk of the emergency department, and I would say, "This is a drill." And I would say, "U.S. News General Hospital, this is Central Medical Control. You're getting 15 patients. There's been an explosion downtown. This is a drill," and see what they do.
And I'd go up, and then.
But really focusing
Drilling.
on drilling and see how they do. So you have to be prepared on every day for game day.
Okay. And then my last question is for you, Tony. Your counterpart in a small rural hospital in the Midwest with limited funding calls to ask what her priorities should be: getting ready for a bioterrorism attack, a flu outbreak, a mass shooting, or a plane crash. What would you advise her?
So, ending with a theme we began with about communication. Years ago, Ian Forster wrote a book called Passage to India, and the epigraph of it was the phrase, "only connect." And the single most important thing they could do in a hospital, a small rural hospital or a big urban hospital, is to connect. And by that I mean connect your employees to each other, connect your institution to other institutions. In that case, there probably aren't any other nearby hospitals. But connect to first responders, connect to social service agencies, connect to other government agencies that can support them, because the connectedness and the knowing the people and having the relationships before any of those events happen is going to be the strongest foundation to responding to them, no matter what the resources are.
Okay. All right. Well, thank you. Well, I'd love to thank my panel right now. Let's have a big hand for them. And we appreciate all the good work that you're doing, and we're learning a lot, that's I'm sure. And thank you very much.
Thank you.